Good evening. My name is Amy. I'm a Community Education Coordinator for Boulder Community Health. Thank you for joining us this evening for this Physicians Information Session on safe, incision-free treatment for essential tremor. Tonight's lecture will go as follows. Dr. Beasley will present for about a half an hour, and then we will use the remaining time for questions. On the bottom of your screen, you will see a Q&A icon. To ask a question, please click this icon, type your question, and then hit enter. We'll take as many questions as we can. On behalf of Boulder Community Health, it's my pleasure to introduce tonight's speaker, Dr. Kara Beasley. Dr. Beasley is a board-certified neurosurgeon and is one of the only dually credentialed neurosurgeon bioethicists in the world. She received her Doctor of Osteopathic Medicine from Midwestern University in Glenda, Arizona, and went on to complete a general neurosurgery residency at the Philadelphia College of Osteopathic Medicine. Dr. Beasley has also completed fellowships in stereotactic radiosurgery and functional and restorative neurosurgery. Her areas of interest include movement disorders, minimally invasive spine surgery, neuromodulation for refractory chronic pain, and the surgical treatment of epilepsy. Welcome, Dr. Beasley. We're going to start off tonight with a short video.
Essential tremor can be a very isolating disease. For many of us, most of us, we're pretty independent. That's the way our culture is, and to have to give up that because you can't feed yourself or you can't sign your checks can be heartbreaking. So the term benign essential tremor is really a misnomer. What it means is it's not associated with loss of other forms of movement, but it is by no means a benign disorder.
I've always had essential tremors since I was a child.
My essential tremor has affected my life for probably at least 25 plus years. And it affected my career. It affected just about everything I have done.
In a work setting, I need to write, I need to be able to sign contracts, I check into hotels, and the shakes hurt. I mean, it makes it very difficult for me to get through those parts of life.
I was ready to try something else a long time ago, but I wasn't into this deep penetration stuff, and that seemed to be my only outlet.
I found on the internet the procedure involving the focused ultrasound, and it was really compelling. I don't have to have a traditional brain surgery. And after that, I got a hold of a gentleman by the name of Lawrence. He answered questions before I actually had them.
The educators at Inside Tech explained a lot of things, and I think they were very thorough.
I spend a lot of time with my patients making sure that their expectations, not only of the procedure and the process that we go through, but also of the expected result, so that at the end of the day, if they've undergone something that's completely elective, they're going to be happy.
They explained a lot of things to me that made sense, and that's why I'm here, and I'm looking forward to tomorrow.
I actually believe that for people who have their dominant hand affected and who are not horribly affected by head tremor or vocal tremor, for those folks, MRI-guided focused ultrasound is great because they can get a result that will meet their expectation and will do so without all of the risks of a surgery. This is somebody who walked in one way and walks out with their life changed for the better in a matter of a few hours. That to me is so rewarding and so exciting.
The first thing I'd like to do after the treatment is to sign my name. It sounds really simple, but it's a wonderful thing for an individual who's struggled to sign your name when you're trying to check into a hotel, rent a car, or do anything. So if I can sign my name without having my hand shake, that's going to be wonderful.
So, good evening. Welcome and thank you for spending a little bit of your evening with us today to talk about this really exciting, very, very rewarding procedure. Next slide. So, the basic facts of essential tremor, as you well know, are that it affects approximately 10 million Americans. It is, in fact, the most common neurological movement disorder, and it's characterized by this uncontrollable shaking or tremor in different parts of the body and on different sides of the body. The very characteristic tremor of essential tremor is that there is no tremor at rest, so that somebody will be sitting with their hands in their lap and you wouldn't know that they have essential tremor. But then there's this postural or kinetic component, so that a person goes to reach for a glass of water and starts shaking, or holds their hand up and starts shaking. But then sitting in their lap, there is no tremor present. Next slide. So there are a couple of treatment options, and obviously the most conservative and the first line treatment option is medication. Medications can, as you well know, can include beta blockers, propranolol, primidone. There are some other medications such as gabapentin, or some other anti-epileptics that have been used. The sad fact is that only approximately 30 to 50% of patients will receive a benefit without intolerable side effects such as low blood pressure, lethargy, fatigue, lightheadedness, dizziness, even passing out. Such side effects can become overwhelming, and as tremor progresses, tremor will always progress over time. Patients will become less and less able to tolerate the medications as they have to increase those doses. The next treatment the second line treatment is considered surgical intervention, also known as deep brain stimulation, where we drill a hole in the skull and pass a wire deep into the brain, attaching it to a battery in the chest wall, and we can electronically control the circuit in the brain. Essentially, neurosurgery is nothing more than glorified electricians, functional neurosurgeons. We are more than glorified electricians. And so we're placing a wire in the brain and controlling the electrical circuit that way. Unfortunately, there's some low acceptance by patients, and this may be due to the invasiveness. I mean, this is quite literally brain surgery. And while it's very safe and very effective, some patients just simply say that they're not going to participate, or nobody's, as they say, nobody's drilling a hole and putting a wire in my brain. And then at the end of it, once it's implanted, it does require follow-up and additional surgeries down the line to treat the tremor and to maintain the electrical stimulation. Next slide. So there is a need for a safe, effective, and minimally invasive treatment that has a positive impact on the patient's quality of life. And that's what we're here to talk about tonight. Next slide. And that treatment is focused ultrasound, otherwise abbreviated as FUS. And it really is a transformative technology. As you can see the video of these patients, this is somebody on the left before and then after the procedure. And when we say after the procedure, that is immediately after the procedure, before they go home. What we do is we use MRI guidance to focus anywhere between 700 to 1,100 different ultrasound sources from around the head. As you saw, there was that cap and frame from around the head. When they pass through the brain, they do not destroy tissue. But when they converge at the base, when all of those 700 to 1,100 sources converge at the base, they heat the brain and cause a small lesion in the brain, altering that electrical circuit. The treatment's non-invasive. There are no incisions, there are no implants, and that means that there's a lower risk of infection and there's nothing that needs to be replaced or maintained. And it is similar in results, as we'll talk about, to the surgical treatments that stimulate or destroy the part of the brain that caused the tremor, also known as radiosurgical thalamotomy or deep brain stimulation, as we just discussed. Next slide. So it really is a reinvention of neurosurgery. It's exceedingly elegant. As I would say, it is the most elegant neurosurgical procedure we have available. We have moved from open surgery to minimally invasive surgery to robotic surgery, but all of those require an operating room or a surgical theater, a large surgical room, multiple tools, incisions, sutures, extended hospital stays, or hospital stays at all, and then ongoing maintenance and programming. MRI guided focused ultrasound is truly innovative in that it is incisionless. It can be performed as an outpatient. In fact, patients go home the exact same day. There's no anesthesia, there are no incisions. A patient will literally walk in with a tremor, and 2.5 to 3 hours later, depending on certain surgical factors, will walk out tremor free or 70% improvement in tremor or greater. And it may help to reduce morbidity. So surgical complications such as hemorrhage, infection, wires breaking or moving, all of those surgical complications. It reduces the morbidity involved with a surgery, the cost, and the resource burden for both patients and hospitals. And so this is innovative in many, many ways. And we are proud to say here at Boulder Community Health that not only are we the only site in Colorado to have a system such as this, but we were the first in Colorado to do this, and we're very, very proud of that. Next slide. So let's talk about the platform. First of all, there's no craniotomy. There are no holes in the skull. We do not have to drill a hole. We do not have to pass anything into the brain. We do have 4 small spots where our frame gets screwed into the skull. That frame, so we numb up 4 sites on the skull and place our frame, and that frame allows us to have precise sub-millimetric control of our target. We then use MRI guidance through the procedure and live thermometry. So I know that exactly how hot the brain is getting in the region of interest, which is also known as the ventral intermediate nucleus of the thalamus, or VIM for short. And then we're able to give real-time patient feedback before the lesion. So we heat things up just a little bit, just enough to stun the cells in the brain, watch the tremor get better, and then look for any side effects that we might have. That's what's truly innovative here. That means that I can be exceedingly precise, as I said, sub-millimetric precision in choosing the spot in the brain so that we are not destroying tissue surrounding the region of interest. It's outpatient with a quick recovery. Patients literally go home the same day. We see them back the next day to look at any side effects they may have, which we'll get to in a moment, and to see how they're doing. And then they can head back. And we have treated patients from all over the country, and actually in a couple of weeks, all over the world. It is compatible with a range of Siemens and GE MRIs. Ours is a GE MRI, and there are minimal complications to this procedure. So I do my procedures on Tuesdays, and I now say Tuesday is my favorite day of the week, because truly it is transformative, not only for my patients, but for our nursing staff and for myself. Next slide. So how it works, as we talked about, is we take these ultrasound waves and we focus them through the brain, accurately targeting the tissue, the VIM tissue that we were discussing. And the MRI is used to plan this spot in the brain, so that in real time, we can not only monitor where we're focusing our ultrasound, where we're lesioning, but we can become exceedingly precise about where we might place our lesion. Next slide. So the first step is patient preparation. Next slide. We do have to shave the patient's head. And the reason we have to shave the head is that sound waves can be deflected by many different things. And so we shave it not just a little bit, but baby smooth. I don't want I do the shaving myself because I don't want any tiny little baby hairs deflecting those ultrasound waves and making it more difficult to reach a temperature. After we shave the head, we numb up 4 spots on the scalp. That burns or stings for about 45 seconds. We use a combination of a long-acting and a short-acting, so I typically use lidocaine and benzocaine with epinephrine, or Marcaine with epinephrine, so that we can get a long and a short-acting. And then we screw our frame to the skull, which feels like a tight hat band, or what I would say is described as a vice. That lasts for about 10 or 15 minutes, and then that sensation goes away. We then bring our patient downstairs. We place a bladder. That flat saucer looking thing is a bladder that holds water. Water is the medium for the ultrasound. And we bathe the head in cool water to keep it cool and avoid any burns. And then I start my planning process. During our treatment, the patient is awake. They lie inside the MRI scanner. So we really can't give them a lot of sedation, because I need to be able to interact with them and have them perform tasks and tell me what sensations they might be experiencing to know that I'm in the exact right spot. And this is absolutely critical. And this is truly, to be honest with you, the magic of the procedure. So we take the MRI images to plan. We then target. We heat up the brain just a little bit. These doses of ultrasound are anywhere between 13 to 45 seconds long. The 13 seconds ones, the short, low dose ultrasound, is to stun the cells just a little bit so that I can look for those side effects and watch the tremor get better and be as accurate as possible. And then we deliver the high doses. The high doses last anywhere between 15 to 45 seconds, and then they go away. So any sensations that patients experience during that time period, they go away pretty quickly after we stop delivering ultrasound. And that allows us to reach a temperature. And what temperature are we looking for? We're looking for approximately 57 degrees Celsius. Anything between 57 to 60 degrees Celsius in the brain. So pretty hot in that area to create a destructive lesion there. Next slide. So the platform, again, allows us to create these sublethal sonications that are fully reversible and get real-time assessment. So as you can see, as we reach 42 degrees Celsius, that allows me to localize in both an anterior posterior, a medial lateral, and a superior inferior plane. We then heat to 50 degrees Celsius, and that 50 degrees Celsius temperature is where we start to see the stunning, and we start to watch tremor get a little bit better and see any side effects. This region of the brain, the VIM, sits surrounded by several other regions, and depending on what side effect I might get, I might need to make a move anterior, posterior, medial, lateral, or a little up or down, and I can get that feedback and make that decision real time. And then when we reach approximately 57 degrees Celsius for our treatment, that's where we get complete thermal ablation of the tissue there. Next slide. So what is the clinical evidence? So this was published in the New England Journal of Medicine, and this was the pivotal trial. So it was a Insightec sponsored. Insightec is the company that invented or created this device. It was a multi-center clinical trial, and the results showed a 69.5% reduction in tremor amplitude at 3 months. And more importantly, this was maintained at 24 months. The CRST is a tremor tool that allows us to evaluate the tremor. And as you can see, with Exablate, there was high tremor at baseline, and with a sham procedure at 6 months and at 12 months, sham procedures had no tremor relief whatsoever. And also importantly, there was a crossover, so that patients who received the sham were then allowed to receive or able to receive the Exablate treatment and had significant relief at 12 months and then sustained at 24 months. Next slide. Also important is the 3-year follow-up. So we achieved 69.5% tremor control, meaning a 69.5% reduction in tremor at that 3-month and 12-month and 24-month mark. At 3 years, that number actually went up to 76.5%. And what they were telling us was that they had tremor relief, they were able to return to work, and more importantly, they were able to enjoy their hobbies and socialize in their life. Tremor can be a very isolating disease. People don't want to go out to dinner. They don't want to go to a party because they might shake and people will stare at them. folks who participated, patients and research subjects who participated in this trial had improvement in their working life, and they had improvement in their social life. Also importantly are the side effects. The majority of all of the side effects, here it's listed as complications, I call them side effects, began within 30 days of the procedure and nearly all resolved. So at 3 years, and this is very important, only the side effects include gait disturbance, imbalance or coordination difficulty, musculoskeletal weakness, and unsteadiness and numbness. And really, if you look at these numbers, 96%, 96 to 98% of all of the side effects that were problematic resolved. And the 9% continued numbness is typically a numbness right around the side of the mouth, and it's not debilitating in any way. The numbers in the parentheses are the percentage of the active subjects that experienced that. Next slide. The most common potential risks or side effects occur within that first 30 days. They usually show up the very next day and then get worse for 4 or 5 days. Typically what they're from is from a little edema or swelling around the lesion as the brain reacts. And so I place patients on a steroid, a Medrol dose pack for 5 days and let them know that typically side effects would resolve in 1 to 2 months. Occasionally it can take 6 to 9 months if they have a lot of edema or swelling around the lesion. And then as you just saw the 3-year mark, what the side effect profile is, which is essentially 96 to 98% of these would resolve. The most common that I tell patients about, and this is really important for you to know as primary care providers, as folks who may be sending patients or seeing patients who have received this treatment, is balance and coordination. Balance and coordination is exceedingly common as a side effect. And again, it typically resolves in 1 to 2 months, can take 6 to 9 months. It can be severe enough, to be perfectly honest with you, that a patient would require a walker or a cane, so some sort of assistive device for that period of time. So I tell people just across the board, I say, look, you should expect this. I want you to come with a walker or a cane with you. And again, take the steroids, and we expect these things to resolve. They can be, upsetting because balance is off and people are figuring out how to get through this, but it will get better. Sometimes gait and physical therapy afterwards can be very effective, but as that swelling or edema goes down, which takes a little bit of time with the steroids intact, it will get better. Infrequent complications that lasted more than 3 months are present. So again, I say in exceedingly rare situations, 6 to 9 months, somebody might experience this, and very, very rarely, as you've seen, would they have a complication at 3 months. But it's really, really important to me. So I'm a bioethicist by training, as you may know. It's really important to me that patients understand from the get-go what to expect. Because if somebody has their tremor gone, but then they have all of these, the balance and the coordination side effects, if they weren't expecting it ahead of time, they might be very upset. But because they know, most of my patients come in and say, yep, you told me this was going to happen. I'm with it. I'm good. And then it resolves over a period of time. Next slide. So you may be asking, who's a candidate for focused ultrasound? Next slide. So you have to be 22 years or older, and it must be a confirmed diagnosis of medication refractory tremor. And what do we mean by medication refractory tremor? These are either people who have functional disability beyond their medications. So they're taking medication, they've tried a couple of different types of medication, and they're either unable to tolerate the side effects of the medication, or the medication is no longer effective for them or was never effective to begin with. It needs to be somebody who can tolerate the procedure. This slide says with or without some form of sedation, but to be honest with you, sedation is in my mind a no-go. And the reason for that is that I have to be able to really interact. This is a very patient participatory procedure. And so I need to be able to interact with folks and ask them what they're feeling, what they're seeing. I have them say certain phrases and move their hands around, and as you saw in the video, test their tremor in surgery so that I know, and their strength in surgery so that I know that I'm in the exact right spot. So what does able to communicate sensations and that they can fit in the MRI scanner. So if somebody is morbidly obese, they're probably not a candidate because there is a table limit. The one thing that people oftentimes ask is sort of who is too old, or is there an upper limit from age? And the beauty of this procedure as compared to deep brain stimulation is there is not. People have a certain level of health that would allow them to have a brain surgery, even a very minimal brain surgery such as deep brain stimulation. They have to be able to undergo anesthesia and sedation and tolerate the operating room. In this procedure, they don't require any sedation. They don't require any anesthesia. And so from that perspective, people can be very elderly or frail and debilitated by their tremor and still improve. In fact, the oldest patient that I have treated thus far is 95. So you're never too old in this situation, as long as you can tolerate laying on the table and communicating the sensations. Next slide. So there are some contraindications, including non-MRI compatible implanted devices, such as non-MRI compatible cardiac pacemakers, allergy to contrast dye, women who are pregnant, someone who's on dialysis or with advanced renal disease, somebody with unstable heart condition or severe hypertension. We do have medications available to treat elevated blood pressure. Anybody exhibiting behavior consistent with alcohol or substance abuse. And this is important because a lot of patients know that essential tremor classically by textbook gets better with alcohol. It'll get a little worse the next day, but it'll get better with alcohol. And so there are a lot of folks out there who have developed substance abuse and alcohol disorders who have essential tremor. So if somebody has that going on, then they're not a candidate. The next bullet point says patients with a history of abnormal bleeding, hemorrhage, or blood clotting disorders. So if a patient is on an anticoagulant for a reason, such as they've had a DVT, or they're on their Coumadin because they have AFib, those patients need to be able to be off of whatever their anticoagulant is for several days prior to the procedure, depending on the drug that they're on, and for 2 to 3 days after the procedure. If that is safe for them as determined by their healthcare provider or their cardiologist, then they would still be a candidate. Patients with history of cerebrovascular disease, such as strokes or brain tumors. Now, I'm going to say this: if somebody had a meningioma resected and that's completely resolved, or somebody had a stroke 15 years ago, I'm willing to treat those patients, but by the FDA ruling, we have to say that these are patients with cerebrovascular disease, strokes, or brain tumors are not candidates. Patients who are not able to tolerate prolonged stationary position. So folks who can't lay still or who have a lot of back pain or neck pain, we do have some pain medications available for those patients, and we try to talk them through them, get them through it, give them a little bit of medication, but not so much to sedate them. But if they say, look, I literally can't lay flat on this table for 2.5 hours, then I say this probably is not the right procedure for them. And again, as a bioethicist, it's super important to me that we don't put somebody through something that they can't get through long-term and reach the end, so that they don't take that risk and undergo that. And also because they need to know what to expect as they walk into our procedure. And then the final one is this thing called a skull density ratio. What is the skull density ratio? It's the ratio of the hard cortical bone to the soft spongy bone in the skull. So the spongy bone will deflect ultrasound waves because it's unpredictable, whereas ultrasound will pass easily through the hard cortical bone. This here states a skull density ratio of 0.45, and we determine this by ordering a CT scan with a specific algorithm, and we then calculate that skull density ratio. Colorado happens to be in the only Medicare region in the country that has a lower skull density ratio. That our skull density ratio cutoff is 0.4, not 0.45. We handle that, we determine that through our process, which is a really great process where patients call a number and they receive all of the education that I'm providing for you now in layman's terms. I then do video conferencing with them if they don't live immediately close to us, and then we arrange that CT. We calculate that number for them. We have treated patients from all over the country because Colorado sits in the only region that allows that 0.4 to 0.45. So everywhere else in the country, there's a cutoff of 0.45. And so we have treated many patients, and those 0.4s are more difficult to treat. We've treated many patients, more of the difficult patients than other places, because Medicare and the insurances will allow that. So people travel to us for those harder skull density ratios. But if you hear that term SDR, or my patient was a candidate because their SDR was 0.45 or 0.57, or my patient wasn't a candidate because their SDR was 0.36 or 0.38, you'll understand what that means. To be honest with you, approximately 86% of people we're finding that we screen with these CT scans meet our 0.4 or greater skull density ratio. Next slide. So the steps to treatment are that they see you as a neurologist or as a primary care provider, and they receive a diagnosis of essential tremor. Then a recommendation is made either by primary care or neurology, or the patient themselves seeks out Neurovive, that's the name of this MRI guided focused ultrasound procedure, and they select a treatment center, of which we are very proud to be a referral center. They then get to ask me questions. So if they live locally in Colorado and it's close enough for them to drive, I see them in my clinic and I ask those questions in person. And if they don't, then we do a video conference where I've reviewed their images, their video of their CRST, or that hand exam, the handwriting, and say, yes, I think that this meets the Medicare and insurance criteria. And then I answer any questions they may have. They then undergo the CT scan, because we're not going to submit them to a CT scan unless everyone feels that this is somebody who would benefit. And then once that CT scan is performed and we have the SDR that we just talked about, and they are a candidate, then they could set up their treatment date. And we have a very streamlined process for that to occur. Next slide. So this is covered by Medicare in every single state in the United States. And to give you an example, next slide, of what some private care coverage is. At the time of the writing of this, Blue Cross Blue Shield did not cover in Colorado. However, as I understand it, Blue Cross Blue Shield does now in Colorado cover this procedure, and other insurances are coming on board. And so we do have private pay coverage in many, many instances. And in those situations in which insurance, they're not Medicare and insurance would not cover this, we do have arrangements that we can make with the patient. Next slide. So we've now reached the end of the formal presentation, as it were, and I was told I had about 30 minutes and I took 33 minutes. So we have physician brochures, we have patient brochures and education that are available for you if you so choose, and you can reach out to us. I think we put our number at the beginning, and I can give it to you again. Our office number is 303-938-5700. So if you have questions after this, you go away and you're like, oh, I forgot to ask this, reach out. We're happy to help educate you. And now I think we're going to move to the Q&A portion of the evening. I'm going to start out with, some folks may ask me, like, so how do you decide between deep brain stimulation and focused ultrasound? So oftentimes it's patient preference, right? There are plenty of people who say, look, you are never going to drill a hole in my head. I'm just not interested in that. It's too frightening. It's too scary. And to be honest with you, deep brain stimulation is not frightening or scary, but it's a personal value type of a situation. And for those people, MRI guided focused ultrasound is an excellent option. The other caveat that I would say is that at this point in time, it is only FDA approved to treat one side. The reason for that is you can have some other complications and movement disorders when you treat both sides. So there is an ongoing study. It has not yet closed. That ongoing study is looking at patients who are treated on both sides. So it may be in the future that we can offer a second-sided surgery. Currently, it is approved for the dominant hand. So for patients who have terrible head tremor, terrible voice tremor, because those things come from both sides of the body, or terrible bilateral tremor, that they would not be happy with just one hand to eat or write or what have you, those patients might be better for deep brain stimulation. But honestly, with patients who say, look, I don't care about my head tremor, I don't care about my voice tremor, or they don't have that. And patients who really, their honest to goodness goal, and I'm very goal oriented, is I want to be able to drink a cup of coffee. I want to be able to sign my name. I want to be able to button buttons or brush my teeth or shave. That's what one of my patients said. He was like, I shaved for the first time in like 25 years. Those folks, this is a very elegant, really, really safe procedure that is instantaneously effective and effective long-term for these patients. And so that's how I would choose one over the other, and why I might push somebody away from this procedure or towards this procedure. Also, this one is really great for folks who would not be a candidate for deep brain stimulation, regardless of whether they're bilateral or they have head tremor or voice tremor. I'll give you an example. I saw somebody who had an infected knee, and they'd had a knee implant, and that knee was infected, and so they were on chronic antibiotics lifelong because they have this implant. Well, that's somebody that I don't want to implant other wires into their brain, and so that person would not be a candidate for deep brain stimulation, and would really be somebody who this would be the only surgical option available to them. Other folks would be, you know, the 95-year-old who was pretty frail. He was 95. I mean, he was a strap at 95, but still 95 is 95, no matter where you live in the country. And so for him, deep brain stimulation really wasn't an option for him because of health issues. And so this was an excellent, excellent alternative. Other ones are folks who are exceedingly active. So I live in Boulder, Colorado, right? So these are folks who ride their bikes and they ski or heli-ski, or I mean, they do all kinds of things, and they do it well into their 80s. If you fall, you will break a wire or a battery, or you can damage the device if it's indwelling, such as deep brain stimulation. And so there are some folks who say, look, I don't want to have anything implanted in me because I do really high impact activities and I'm concerned about those breaking. So those would be other folks who would be really great to consider for this procedure.
Great. I'm going to jump in here for a minute
Yes.
and remind folks on how to ask questions. Go to the bottom of your screen, click the Q&A icon. You can type your question in there and then hit enter, and then Dr. Beasley will be able to see your question. So we'll give that a couple minutes and see if we have any questions come in.
Another question while we're waiting to see if anybody else has other questions is, you know, when should somebody consider MRI guided focused ultrasound? And again, that goes back to a values-based decision. I have treated folks who, for instance, I've treated somebody who's an attorney and he's a trial lawyer. And so he tremors, not because he's nervous, but because he has a physiologic medical problem. Well, if he's in front of a jury or a judge, they don't know that. Or I've also treated a CEO of a company. And again, if you're running a board meeting, confidence and those kinds of things are super important. And so to have that tremor and to try to worry about suppressing it when you're in a meeting like that so that you don't look nervous, those folks, even though their tremor wasn't nearly as bad as the guy who like is shaking so bad that he can't like drink a cup of water, for them, their tremor negatively impacts their life in such a way that it's super important that they get some tremor control. And so it's really not that you should wait until your tremor is horrible and nothing works. It really comes down to a personal values-based decision, depending on your lifestyle and your values and your quality of life and all of the things that may affect you in your day-to-day activities. And so that's why it's really important to not wait until the end or say, no, this isn't something you would want to consider. You're not bad enough yet. That kind of a thought process can really limit the opportunities for people who would benefit in a way that would be very effective for them. Now we have the awkward silence.
Yeah, I'm seeing if there's any questions. I don't see any yet. Well, is there anything else you'd like people to know?
What I really want you to know is it's never a bother or a problem to reach out and just say, hey, I have this patient or I have a question. You're never going to bother me. This is the passion of my life. Doing movement disorder surgery is truly my passion in life. And it is the most rewarding thing I do. I'm supremely honored to be able to offer procedures such as MRI guided focused ultrasound for essential tremor to my patients and to change lives in that way. And so, as you may tell, I love to talk about it, and I'm never, ever, ever gonna not have time or say that this isn't time. And so I'd love to chat with you. I'd love to talk with you. If you have a patient, if you just have a question, you can call our office. Again, our number is 303-938-5700. And again, I'm truly honored that you chose to join us and spend some time with us tonight to learn about something that I'm truly passionate about. And so I want to thank you, and I want to wish you an absolutely lovely day.
Thanks, Dr. Beasley. And I want to let everybody know that a link of the recording of this evening's program will be sent to you by email early next week. Thanks again, and have a good night.